Hello, my name is Simon Parson. I'm currently the Regis Chair of Anatomy at the University of Aberdeen, where I've been working on motor neuron diseases now for about 12 years and also prior to that for another 5 years when I was previously at the University of Edinburgh. What I'm talking about today is perhaps a form of motor neuron disease which you're not all familiar with, but it's one where we've really had tremendous success over the last 10 years. So what I'm really hoping to give you is a bit of a sense of hope in a condition where we've come from really very little hope to now where we're in a very much brighter situation for all those who are affected by this condition. So I'll start off by telling you what on earth we're talking about. But something I've already alluded to is, and something which is a thing I like to talk about quite often, is that we think about motor neuron diseases, not motor neuron disease. And this may seem like a small thing, but I think it helps us to understand that there's a very wide range of conditions which have ended up in a diagnosis of a motor neuron disease. And by that, I mean there are many pathways how somebody might end up with that diagnosis. It might be inherited, it might be genetic, or it may be due to a host of causes that we still don't really fully understand. But I think it's important to know then that when we start to develop specific treatments, they won't always be for every patient. Sometimes they'll be for only certain subtypes. And I guess that's what I'm talking about here. So I want to talk about a condition called spinal muscular atrophy. This is what we'd call a form of lower motor neuron disease. So I think some of you might recall, we have a group of neurons in the brain that we call upper motor neurons. And these are, if you like, where we think about movement that we'd like to do. Like we start walking, we start talking, we start to write. And those upper motor neurons communicate with these lower motor neurons, and those are the ones found in the spinal cord. So down the back in your vertebrae, and those lower motor neurons are what actually contact all of the muscle in the periphery. Often called the final common pathway, because this is how you can execute a movement. So that's where we go from thinking about it to actually doing it. So spinal muscular atrophy is a type of a lower motor neuron disease. We've known about it for quite a long time. You see, it was first described in the late part of the 19th century. It was first described in Germany. I've just shown you a photograph here of a little girl actually from America who's got actually quite a mild form of SMA. Because what you'll see here that really marks this out as unusual is that it most commonly affects children. And even within that group of children, it most commonly affects really young children. And if you look at the line right at the bottom, it shows quite how severe and distressing this condition is, in that many of these children will be diagnosed before they are 6 months old. And after that diagnosis, they're unlikely to live beyond their 3rd birthday. And I think that's something quite surprising. These are often children who we don't really hear about in the news, don't hear about in the press, and don't really meet those families because they have such a short life. They never make it to playgroup or to nursery or to primary school. So, they don't get beyond the family setting. So often for these children, it's just a very, very short and sad life, really, for them and their patients. So, this was the status up until really only 10 years ago. It's very severe, the disease. So how do you come to have SMA? Well, again, what makes it slightly unusual is it's inherited, and almost every case of SMA is inherited. So about 98% are directly inherited from parents. So how does that come about? Well, it's the type of genetic condition we call recessive, which means which if only one parent carries the gene, there won't be any children who will be affected by the disease. But if both parents carry the gene, then there's a 1 in 4 chance that every child they have will be affected by SMA. So if you look at the little picture on the left, you'll see that we're showing that the mother and the father are both a carrier, so they're half blue and half green, whereas the blue is the carrier part and green is the healthy part, if you like. And you see below we've got a 1 in 4 chance of what we've shown here is a purple child who's affected and they will have SMA. We've had a 2 in 4 chance of having a child who will be another carrier, who might go on to pass that on to yet a further generation. And we have a 1 in 4 chance of having a completely unaffected child who also won't carry that on to a future generation. And that happens each time there's a birth. And it isn't a case that you get one of each of these if you have 4 children. You could have 4 children all affected, or any combination. It is quite a rare disease. So the carrier rate's about 1 in 55 of the population, which means, if you sit in a room of 55 people, there's a chance that at least one person there will probably be a carrier. The incidence then is quite low. It's about 1 in 6 to 10,000 live births. And that means for an area like where I'm based, up in Grampian, where the birth rate is about 6,000 per annum, we might expect just one child affected by SMA to be born each year. So this is already a little bit different from many of the types of MND you've heard of before, where only a few of them are inherited, and for only a few of those do we actually understand how they're inherited. So we have a really two unusual things here. It affects mainly children, and it's almost always inherited. Now, a little bit of genetics, because this helps us understand how we've managed to do so well in producing therapies and the treatments for these children. So you may have heard occasionally we talk about genes, and we talk that genes make proteins, and these proteins have lots and lots of jobs in cells, and it's those proteins which keeps everything going. And if something is wrong with those proteins, it can affect all those things, from whether they work well or not. So when we talk about spinal muscular atrophy, we now know it's caused by a defect in a single gene, and that's called SMN, which stands for survival motor neuron. Maybe not surprisingly, because it's known to affect the survival of motor neurons, of those lower motor neurons in the spinal cord. So we have a gene here called SMN, and rather unusually here, and perhaps to help us understand this disease, there are actually 2 forms of this gene. So we have a little one in blue called SMN1, and a little one in yellow called SMN2. So what you see in the picture, and you don't need to understand that particularly, but to say that normally, so hopefully in most of us, our SMN1 gene, completely normal, completely healthy, and produces large amounts of normal, functional SMN protein, which will keep our cells healthy and active and long living. But we have a copy of that gene called SMN2. That gene in all of us has got a defect in it, which means it only produces some of this nice healthy protein, and that's what you can see in the nice grey circles. And the if you like, the unhealthy protein it's produced is in blue with a cross through it. It's not normal, it isn't useful, and the cell can't use it. So if you look at that and you think about it in terms of maybe percentages, we seem to have about 120% of the protein that we'd like in a normal person, and that's just fine because it's over 100. So in SMA, what happens is the SMN1 gene is that inherited defect. That's what we inherited from our parents, that our SMN1 gene is not working properly. So now all we have left is this SMN2. But that small amount of protein is enough to keep our cells alive, but not for a long time. That SMN2 gene is a bit more complicated because you can have several of them. You could have 1, 2, 3, 4, or perhaps even more. And then you can see if you had two SMN2 genes, you'd produce a little more protein, 3, a little more protein, and 4, a little more again. And that amount of protein will determine exactly how severe your type of SMA is. So we'll see there are 4 types. Type 1 is the most severe, where you've got the least amount of protein and the shortest survival. Type 4 is a higher amount of protein, more like normal, with the longest survival. But that type 1 is most common. So here in this disease, the most common type we see is the most severe, and that's also quite unusual. A little statement at the bottom says that SMA then is a disease of low protein, not of no protein, because with no protein, you would not be born. So even for the severe children, they've got some protein. But the more you have, the less severe is the disease. Hopefully that wasn't too complicated. But what this has allowed us is to think about 2 forms of treatment that we might be able to apply. So at this point in all my talks about SMA, I always like to just stop and think about really the first patient who I ever met. And it was the family of this little girl here. So her name was Estella. Her mother was Spanish, and Estella means star. You see she's wearing her little Superman or Superwoman baby girl. And there's 2 very stark figures to the left. And I think, given what I've already told you, perhaps you can guess. So she was diagnosed when she was 8 weeks old, and actually she passed when she was only 8 months old. So this poor little girl and her family, all we could offer her was palliative care. We had no trials, no therapy. There wasn't anything we could offer her at all. And that's one of those things I always remember, I always think about, and I think that's helped really to spur on some of the work I've done over the years in this area, to make me think, well, we should be doing better. So let's have a think about how we have progressed from this time when we could offer nothing. So what I've told you is we've had a lot of success with the therapy because we had a gene. We had a single gene that we knew we could aim for, and we knew it was about a single protein. And because we know it's a disease of low protein, the idea being is we just need to make these cells and these children have more of this protein. If we can give them more protein, they should be healthier. And at that same time, other researchers were working and they found some specific areas of interest in terms of the genetics, and also the technology for carrying out the kind of processes we call as gene therapy were becoming more advanced. So as we knew more about the disease and as more of the technical innovations came along, we were able to bring those 2 together to start to think about a therapy. And just to give you the kind of punchline almost first, is that at this time in Scotland and actually across much of the Western world, there's availability now of 3 different therapies for these children. But they all do the same thing. They all increase the amount of that healthy, functional SMN protein in cells. So from left to right, and I'll come back to these, it's the order in which these were first approved. And the one to the left we call nusinersen, and that's a way of making that not very functional SMN2 gene work a lot better. So it's saying, we have got a gene that's a bit slightly rubbish, can we make it do better? That's the same process as the one on the right, which is risdiplam, the most recent therapy, and that's also aiming to just improve the function of that slightly poor quality SMN2 gene. Whereas the one in the middle, the Zolgensma, is taking a different approach, and that's saying, let's give you back a healthy SMN1 gene. So that's a rather more traditional form of gene therapy. Okay, so these are all, but they all produce more protein. And don't worry about the images so much on the right. I wanted to put a sort of picture there, but I really want to show you a time scale here. And that, if you look here from a gene, which I said before, was only identified in 1995, And the specific way it worked was only found another 10 years later, about 2004. And then within 13 years, we've got a phase 3 clinical trial. And you may well know that's the most advanced type of trial. That's after we've been through all of the earlier types of clinical trial. And these are the ones which will normally lead to approval. So that report was, you'll see, was actually fully reported after the drug had been approved. And these drugs have always had a very advanced route to therapy. When you're dealing with such a severe and a rapid life-threatening disease as SMA, clinical trials are able to move a lot faster as soon as they're seen to be having an effect. And in these children, that effect was they were surviving longer and they were doing better. So you'll see we actually approved this first drug in 2016 in the States, and it was shortly approved after in the UK, and it's now widely available in Scotland since 2022, although it was available prior to that through other agreements, but now very broadly available. And actually, as of just earlier in the year, it's now also approved for beyond the most severe patients, so beyond those type 1 children to actually to type 2 and type 3, so the slightly less severely affected children are now also covered by this. And I think that the final point here is it's a great treatment, but it's not a very pleasant treatment. This is delivered by lumbar puncture, so that's into the fluid around the spinal cord. And these children have to come to a hospital about every 4 months for the rest of their life to have a top-up injection of this drug. And that can be quite an unpleasant process. So, it's worth keeping that in mind. But these children, largely, most of them when they're treated, are surviving much longer than they normally would have done, and therefore also gaining more of the functions that they wouldn't have. So these very severely affected children don't learn to hold their heads up, don't roll, don't crawl, and certainly don't walk. And now many of these children are able to do those things. They're not completely well, but they're doing fantastically better compared to their untreated prognosis. So here's our gene therapy, and again, I just want to concentrate on those sort of timelines. So you'll see this again. We understood the gene. This was also reported as a phase 3 clinical trial in 2017, approved a little bit later in 2019, and this is really targeting the youngest patients because for various reasons, because this is a viral therapy, if the child is too large, it's not actually safe to be delivered. So what's really important here is we have to diagnose these children early. And in order to do that, we need something called newborn screening. And that means that we would be adding SMA to the heel prick blood test at birth. And that would allow us to identify these children. And that has not been the situation in the UK up until very recently, and I'll come back to that. That little line at the bottom, the only thing that's fallen off it after the 2.5 would be a capital N, because it's an extremely expensive therapy, but you only have it once. So with the gene therapy, it's a single dose to a very young child that should be their treatment for life. And that's saying here is a healthy gene. And just very briefly, our most recent therapy is called risdiplam. And what we see here is, firstly, this is very easy to take because it's a daily liquid oral therapy. So you were to take it like any other liquid medicine, like a penicillin that you might have for your children. This was approved a little bit later. This was for 2020, but this is now approved for both all types 1, 2, and 3. And there are even trials now for the oldest patients, because those type 4 patients are in the much more adult age group, perhaps in their 40s or even a little bit older. And those patients are more in the age group of the MND patients you might be used to hearing about, or you may be even yourself. But these quite rare cases now, we're also seeing whether or not these treatments can help them. You'll see we were approved here in 2022 by the Scottish Medicines Consortium. And this is a really interesting advance over the last few years. And all three of these therapies are available to patients in Scotland at the moment. Which I think is absolutely, it's fantastic in that time scale, how we've come from no hope to actual achievable therapies that are improving the lives of children and their families and carers, in our home country. Just out of interest, I've always been amazed that actually when we start to have some traction and some progress in a field, that actually the pharmaceutical companies' engagement and involvement actually increases. Because what we've actually shown them is this is a disease which is treatable. And once we've shown it's possible, a lot of drug manufacturers get far more interested, that they can see there's a future and it's worth investing. So actually this trial landscape has really increased over the years since we first had a hint of success in a clinical trial. So I think what you'll see is that when we start from zero, it's a big first step to get a first treatment at all. But once we've got that one, it really stimulates our development in other areas. So, and we've seen some of that in M&D now with some successes, again, which I will return to very, very briefly a little bit later. This is something I mentioned, and actually it's really fantastic to say that in Scotland, but not in the rest of the UK, we will be introducing newborn screening for SMA from early in 2026. This is something which a lot of us in the community have been advocating for, and a group of us, including authors from the Scottish government, published an article on this in 2022, and it's really fantastic for us to see that this is happening, because this means we can identify those children as early as possible and we can treat them as quickly as possible, because we all know that the sooner we identify and treat any motor neuron disease, the greater is the chance of success. In very simple terms, motor neuron diseases involve motor neurons dying. We do not know how to replace motor neurons. So what we're doing is protecting all those ones that are still surviving. So always early diagnosis, early treatment will always give us the best outcomes. And here, newborn screening is what really allows us to do that, because these children can deteriorate incredibly quickly, even over a case of weeks, while we're thinking about what to do. So this is a real step forward for Scotland. It isn't the case in the rest of the UK, but hopefully this might lead to that happening. Just to say, research hasn't finished, and my own particular research, which I'm just showing you just a small amount here as a bit of a taste, really, is that we've gone back to look at the basic pathology of the spinal cord in patients, because that hasn't been done properly for 150 years. And we've gone back and really found there's a lot more happening in the spinal cord than was first described. And it might mean there are more things we should start to be thinking about in terms of the treatment and therapy. And I've been particularly interested in the overall changes in the spinal cord, and also in the blood vessels which supply that spinal cord, which I will talk a little bit more about. So there's still a lot of ongoing research, even in an area where we've had fantastic success. Because that success is still not enough, we can do better, we can do more to ensure that these children have a long and healthy life. We are treating them when they're only a few weeks or a few months old, and we hope they will be able to live healthily until they're perhaps in their 80s, just like everybody else. So I say, here's a piece of work, and if you just look at the pictures on the left, you see we have a control of SMA, and those big purple splodges are the motor neurons, and you see our SMA spinal cord. Well, there are no large motor neurons left. There's a few small and healthy ones, but almost no large ones. And these patients at post-mortem, their historical post-mortems, have lost hundreds of thousands of motor neurons. So it's very dramatic, really, that loss. And just to say, how's this associated with the other M&D forms, and I think one thing we can really look at is that top left. I'm sure many of you heard about atrophy, a drug which is like the nusinersen. It's what's called an antisense oligonucleotide, and that's been developed against one of the inherited forms of MD, which is this SOD1 type. And again, where we have a gene and where we know an action, we've been able to use these approaches to actually target that really successfully. But as you know, that's only for some MD patients, because they are a type of MD, not all MNDs. There are other trials going on as well, looking at other genotypes. You see the C9orf, you've probably heard of, and the FUS. And even below, looking at these gene therapies with these disabled viruses. So I think in SMA, we've learned a lot about turning these scientific and clinical ideas into actual therapies, and those undoubtedly help other groups and other researchers and other clinicians to lead forward on that. And again, some of our work here is I'm really interested in the other cell types that might be affected, because it turns out that often motor neuron diseases don't only target motor neurons, they actually target other cell types too. And in SMA, one of those important cell types are actually those that make up your blood vessels. And we're very interested to know whether or not these might be making matters worse, making us lose perhaps more motor neurons, or even maybe more quickly lose those motor neurons. So we're really hoping to understand this a bit better, and we're doing a whole load of work here and have for many years now to understand what's the process of that, and is this something we're thinking about for future therapy for children to make sure they keep a long life. And I think if you just look at the picture on the left, everything in green is a motor neuron, and everything in red is a blood vessel. And if you look on the right, that's our SMA sample, and you'll see there's still quite a few of the large green motor neurons, but there's very few of the red blood vessels. And that makes the environment quite unhealthy for motor neurons, and I say perhaps really isn't helping the disease. So that's what I've been working on for a number of years. And just to finish off by saying, really, thank you to people that I've worked with all around the world, but particularly that because we often work on post-mortem tissue from children who have died of this disease, it's the fantastic, really, ability and will of those parents to allow for post-mortem to be carried out on their children, to help future research, to help children who might be born in the future. And that's an enormous sacrifice which those have made. And they've worked with my clinical collaborators all around the world, but actually mainly in the United States. And that has enabled us to do this work. So just to summarize, really over the space of slightly less than 10 years, I've gone from a lecture where I had to say, this is a completely untreatable, severe childhood-formed motor neuron disease, to say that now we have 3 available therapies. And the sooner we can target those children, and in Scotland with the newborn screening, that will improve, and we will be able to ensure long and healthier lives for all of those children. So I hope you've listened today, and thank you all for listening today.